Welcome, everyone, and thank you so much for joining us for the fourth installment of the Evolution of Mindfulness speaker series, where today we will explore mindfulness in U.S. healthcare, breaking barriers, creating change. So my name is Frances Sadi, and I am the Associate Director of Non-Degree Programs at Brown University's School of Professional Studies. At Brown, we're proud to offer a growing portfolio of evidence-based mindfulness programs, including short courses, teacher training certificates, and free public events like today's talk. At the Brown University School of Professional Studies, our mission is to develop innovative, rigorous, and flexible education programs that empower dynamic professionals to lead positive change in the fields and communities. Our mindfulness offerings, developed in collaboration with the Mindfulness Center at Brown University School of Public Health, reflects this commitment, integrating scientific research, contemplative traditions, and real-world applications to support resilience, compassion, and well-being in a rapidly changing world. Earlier this year, we launched the Evolution of Mindfulness speaker series as a way to spotlight the leading voices who have helped shape and are continuing to shape the field of mindfulness. In our first sessions, we were honored to host pioneers such as Jon Kabat-Zinn, Richie Davidson, and Zindel Siegel, individuals whose work have helped lay the foundations for the scientific study and clinical integration of mindfulness as we know it today. Today, we turn to the future. As the field of mindfulness continues to evolve and mature, it is critical that we elevate not just the voices that built the foundation, but those who are pushing the field forward, those who are asking the next set of questions, pushing boundaries, and reimagining what is possible for mindfulness in modern society. In that spirit, we are thrilled to be joined by Dr. Isabel Roth. Dr. Roth is an assistant professor at the University of North Carolina School of Nursing and an emerging leader at the intersection of mindfulness, healthcare, and public health. Her work focuses on expanding access to evidence-based mindfulness programs for diverse and underserved populations, particularly individuals managing chronic health conditions such as chronic pain and patients receiving care through the federally qualified health centers serving rural and economic diverse communities. With expertise in implementation science, behavioral health, and integrative medicine, Dr. Roth is pioneering new models for bringing accessible, practical mindfulness strategies into primary care and community health settings. Her leadership in large-scale clinical trials, including a multi-site study on mindfulness for chronic low back pain, reflects a broader commitment to make science-backed approaches to health and resilience available and sustainable at scale. Drawing on her work across a wide range of communities, including those from different cultural, religious, and political backgrounds, Dr. Roth's research reminds us that mindfulness, when rooted in accessibility and respect, can serve as a bridge, offering tools for healing, resilience, and connection across diverse populations. In today's conversation, we'll explore how mindfulness is being reimagined, not only as a personal practice, but also as a public health resource capable of supporting well-being at both the individual and system levels. We're also honored to welcome back Dr. Eric Laux, who will facilitate today's conversation. Dr. Laux is an associate professor at Brown University and director of the Mindfulness Center, where he leads internationally recognized research on mindfulness, heart health, stress, and behavioral change. Under his leadership, the center has become a global leader in rigorous scientific research and innovative mindfulness and teacher training. Before we dive into the discussion, just a few housekeeping notes. First, we are recording today's conversation, and we'll make sure to send out a link to the recording later this week, along with some additional resources on our mindfulness program offerings here at Brown. Second, throughout the conversation, we invite you to engage deeply. Please do use the Q&A feature found at the bottom of your Zoom screen to submit your questions. And while we may not get to every question during today's session, please know that your input is valuable and that it informs our ongoing dialogue. Lastly, while we can only touch upon the surface of this topic in a session like this, we hope that today's conversation inspires new insight ongoing curiosity, and a commitment to bringing mindfulness into your work, your communities, and your daily lives. And with that, it's my great pleasure to turn things over to Dr. Isabel Roth and Dr. Eric Laux. Thank you both for being with us, and thank you to everyone online. We hope you enjoy the session.
Thank you, Fran. Yeah, delighted to be here with you today, Isabel. I know we've known each other for a couple of years. I think you interviewed me for a study, and then I was like, wow, she's doing cool stuff. And then I think I interviewed you for a study, and then we've started to collaborate in a number of different ways. So thanks for being here today. Maybe
Glad to be
just
here.
yeah, thanks. Just a couple other little shout outs. I think you're immediate past president of the American Public Health Association section of Integrative Complementary and Traditional Health Practices. And also, you're receiving a lot of awards these days, even just last year, an award from the American Public Health Association for outstanding contribution to integrative, complementary, and traditional health practices, as well as an award from the NIH with their Community Partnership Award with the HEAL Initiative. So it's been really fun to see not only the work that you're doing, but also just you stepping up into leadership in really important ways and doing so with humor and humility and real insight with a very pragmatic angle to it all. So really, really glad you're here. I think with this seminar series, we're trying to offer some continuity by asking a similar question to begin with. And so be curious to hear what brought you to be interested in mindfulness originally, either personally or professionally, or even preferably both.
I always have a bit of a hard time answering this question because I don't remember exactly when the interest began. My aunt became a yoga teacher when I was 10 years old. And that year, we all got yoga mats for Hanukkah, and we had a little yoga revolution in our family. My grandparents, who I grew up a mile away from, started practicing yoga every day. We started doing yoga at family gatherings. So I know that yoga and with it an introduction to mindfulness practice happened really early in my life. And I also danced a lot, as that was my main hobby growing up. And mindfulness was woven in with some of the dance classes that I took and different forms of dance that I was exposed to. And then I think the intellectual kind of really deep commitment happened in college for me. I took a class my first semester called Bridging the Mind-Body Divide with Ann Cooper Albright, who's an incredible dance scholar. And we read Thich Nhat Hanh, The Miracle of Mindfulness, which was a book that really changed my life, and also studied philosophy and feminist theory, and the whole class happened in a dance studio, so we were moving the whole time. And I still feel like I'm in that class in some ways. Like my whole career is just a continuation of that exploration of bridging the mind-body divide.
Yeah, sounds powerful. Just the title of the talk, Bridging the Mind-Body Divide, along with the content of the course of moving the body and seeing access to all these insights, say from Thich Nhat Hanh and others. It's great. Yeah. Well, why don't we maybe shift if you'd like to give the audience a bit of an overview of some of the work that you're focusing on these days, and I think that'll give us a good anchor point for folks to really understand what you're up to and some of the impact that you're having.
Sure. Well, I'll share a little bit about the project that is taking up most of my energy these days. This is a study that is one part of a career development award funded by the National Center for Complementary and Integrative Health. Of course, my views don't represent the National Institutes of Health, but I'm really grateful for them for supporting this work and supporting making these types of practices more accessible. So just to kind of zoom out for everybody, most of my work is focused on chronic pain. At this point, about a quarter of American adults experience chronic pain. So before the pandemic, that number was 20%, about a fifth of American adults. And unfortunately, it's just getting worse. And pain is complex and it's hard to treat with our existing medication options. There is a high risk of opioid use disorder, which I'm sure as many folks know, we've been really struggling with for decades in this country. And it's debilitating, it's expensive. People sometimes have trouble working when they're dealing with high impact chronic pain. So from a public health lens, we're always thinking about, well, how can we utilize best practices to address some of these big challenges facing our society? So primary care is where most people go to treat their conditions. And so primary care providers are really that first line of defense, especially for vulnerable populations. And what I mean by that is folks who really can only afford to go to primary care and may not be able to see a specialist. And clinical guidelines at this point recommend practices like mindfulness-based stress reduction and other integrative non-pharmacological therapies as the first approach for chronic low back pain and some other chronic pain conditions. But these types of therapies are really not reaching the low-income populations who are at greatest risk for chronic pain and the potential risk of related opioid misuse, abuse, and so what we are exploring is using something called integrative medical group visits. So group visits combine peer support and health education with medical care and complementary and integrative health modalities. And they were developed to make some of these complementary and integrative health approaches really accessible to lots of different communities. So integrative medical group visits, um, they combine traditional chronic pain management and education, really trying to understand pain, stress, inflammation, how all those things work in the body, learning about what types of medications we should be using and when we should use them, and how all of this relates to sleep and other lifestyle um, behaviors, as well as depression. And then the group is also really based on the foundations of mindfulness-based stress reduction. So we learn some of those principles. It's not a full, it's a very adapted version of mindfulness-based stress reduction. People learn chair yoga, we learn self-acupressure, self-massage, anti-inflammatory nutrition, and how to navigate challenging communications. So this is a 9-week program, which we've been delivering via telehealth since the pandemic. It was previously tested in a large randomized trial that was led by Dr. Paula Gardner, who developed this adaptation. And it's billable through existing primary care billing codes. This curriculum also has an app that goes with it and a paper manual, super different sort of options for what people prefer. And our hypothesis is that this may address the quintuple aim of healthcare improvement, that this could actually improve population health by reducing patients' symptoms, their high impact chronic pain. It could reduce costs to the healthcare system in terms of like high cost emergency room visits. It could improve the provider experience because the providers are actually getting to spend a lot more time with their patients and getting to know them on a different level. It could improve the patient experience because the patients are getting to meet other people who are going through something similar to them. They're getting to spend more time with their doctor, and they're really getting a lot of health education through this. And then finally, it could improve health equity by improving access to care that might otherwise be financially out of reach for many. So this research, this program that we're doing is really aiming to test strategies that address some of the big challenges that we face to implementing integrative medical group visits in community health centers, and specifically federally qualified health centers that receive funding from the federal government. So some of the strategies that we're testing are training our providers to deliver this curriculum so that folks who are embedded in these clinics can deliver this program, providing ongoing coaching for the clinicians who are leading the program, orienting patients to this new model, because receiving care in a group is really a different way of receiving healthcare for a lot of people that they may not be familiar with. They may have never heard of mindfulness or some of these other practices before. And then, especially for our rural folks, making sure that everybody has access to the internet and seeing what we can do to partner with our patients so that they can easily access telehealth. And then we're also testing out this strategy of pairing an app based curriculum for patients so that they can access all these materials on their phones as well. So we're looking here at really trying to understand who is signing up for this program, or who are we reaching with this, implementing this program in low-income clinics. How effective is it? What are the patient-reported outcomes? And is this really impacting provider well-being? No one's ever really measured that before. We're looking at if this is acceptable and feasible. We're trying to understand if this can really be done in a way that works for the clinicians and for the patients. We're also looking at some implementation issues like cost. How much does it cost to implement this from the perspective of the patients? What are they paying in terms of copays or internet access costs, as well as to the clinic, who has to make the decision to take on this new program? And then are we staying true? Are we maintaining fidelity to the program as it was initially designed? What kind of changes do we need to make as we adapt into real world settings? And then finally, once we step back some of the supports from the research team, are these clinics able to maintain and sustain these programs in a long-term way? So that's really what we're looking at here. So just a little bit about what patients are saying. They said, I really liked it. I wish we could do it again. I really liked it being virtual. It made it easier for us to be there and be present. I felt better after every session. I really liked the meditation and deep breathing exercises, listening to the breath, the acupressure, offering them choices. One person said, I'm not a big group person, but being in it virtually was really great for me. So lots of interesting perspectives from what the patients are saying. And where this is all going is that we are partnering with our state association, the North Carolina Community Health Center Association, to partner with clinics throughout our state. We're hoping to test this in a large randomized trial where we would actually randomize different clinics to receive different supports. And then eventually we see this leading to increasing access nationally, and trying to build out a way to provide supports to clinics around the country to offer this type of care. So that's just a brief window into what I've been working on lately, among many other things that I'm sure we'll.
I've been really interested in that quintuple aim of, when we were doing focus groups with like health insurers and policymakers and others, they were talking a lot about how it's really important to not only see the health benefits, but also the cost benefits, but also the patient experience. Like, are people going to show up to these programs if they make them covered by health insurance? But then also that quintuple aim side of like the provider experience. And we know that a lot of clinicians are dealing with burnout these days. And I was reading your 2024 paper where you're a senior author in the Global Advances in Health and Medicine, where looked like you interviewed clinicians around their experiences with group medical visits, and be curious to hear a little more about your findings in that regard around, we often think about the impacts on the patients, but when physicians or clinicians can provide these longer form group visits where they're actually getting to spend quite a bit of time with the patients in group settings, what is it like for them? Could you maybe share a little more about some of
Yeah.
the findings there?
Yeah, I mean, there's a lot that we're hoping to share from those interviews. So before we started this clinical trial that I just talked about, we interviewed folks around the country who have been doing these groups for some of them for decades, just to try to understand what they'd gone through to make these groups happen and how they'd made them successful. And one of the things that stood out to me is that many of the clinicians I interviewed had also moved into leadership positions within their clinics. They were now the chief medical officer. And so many of them are leaders. They're leaders within their clinics and they're leaders nationally. And they're so passionate about this work and they really want to share it with other people. And I think it's because it's something that has sustained them in their practice of medicine. And within the community of folks who've been offering group medical visits for a long time, we often kind of talk about this being a burnout prevention strategy, but there really hasn't been a lot of research into whether that's kind of empirically true. And so one of the things I've been wanting to do with this study, I wanted to capture, okay, what is the experience like for you? What makes the difference between this being something that supports you and something that might be a drain on you as a provider? And I think what we heard was that when there was support from their clinic, when folks had a little bit of administrative support or a staff person who was helping them to run the groups, that being able to offer group visits was something that really helped people connect to their purpose as a healthcare provider, that they were able to deepen their relationships with patients. They're able to sort of sit back and listen more. 15 minutes is typically what we're seeing in these primary care. People are just in and out, in and out, in and out, and providers are saying the same thing over and over again to patients and not able to really do some of what we hear are the best practices all the time. I think people do their best, but 15 minutes is just not a lot of time to practice motivational interviewing where you really get at why do you want this health change, right? Or what matters to you? And so I think in groups, that's able to happen. You can have those deeper conversations. And I think crucially, you see patients helping each other. And that's really empowering for the patients and it's empowering for the provider too, to see patients supporting each other in that way. But I think one of the crucial things, and we pointed it out in that paper that you mentioned, is that there has to be some support for the providers too. It can't just be all on them to be the champion for the program. So I think that that little bit of someone helping them goes a really long way into making this something that they can celebrate and that actually helps to maybe even change their career and catapult them as a leader.
Yeah, I think with their mindfulness-based programs like MBSR or MBCT, where a decent amount of the program can be the peers inspiring each other because they're all working with either similar conditions or complementary conditions. And so as they're learning things, they're sharing what they're experiencing, and that can really lift up the class and help with behavior change and social support and community. And so you can see in these group medical visits that might be, say, 90 minutes long or however amount of time that they get that opportunity rather just being in one room where the physician comes in or the clinician comes in and it's a one-on-one interaction. They're actually getting inspired by each other, but then they're also getting 90 minutes of time or however long it is with the clinician as well, rather than just the 15 minutes. So you kind of get the power of the group there, which could be a wonderful thing, along with the ability with the billing codes to be able to make it financially viable for clinicians to be able to offer this kind of thing too. So, I'd be curious to hear more, like, what this was a question that came from the audience. Like, how do you see healthcare coverage, like health insurance reimbursement, shaping the future of mindfulness-based programs? Could wider coverage change how mindfulness programs are taught or delivered in clinical settings?
I think it's a huge new frontier and probably so multifaceted, right? I mean, I think that one of the biggest challenges we have right now is that mindfulness isn't directly reimbursed, right? So it's not like you have a code for mindfulness that people can go in and bill for. I think the question is, if you do have a program that explicitly pays for mindfulness, what are the parameters of that? So is it that the physician is the one who has to supervise and bill, and does the physician need to be present the entire time for a mindfulness program? Or could you have teachers with a particular credential working in healthcare systems? And if they're going to work in a healthcare system, so that's happening already. There are already mindfulness teachers who work in healthcare systems. But what's happening is that each healthcare system has to create their own process for sort of how they're going to decide to allow a mindfulness teacher into the system. And there's no kind of national standard around that. And so I think what you could see if there was increased reimbursement is sort of a professionalization of the field of mindfulness, that we'd move from a place where you have individual programs like what you've built at Brown, which you all have your own kind of process of what it takes to become a mindfulness-based stress reduction teacher. I think if you're going to work with healthcare systems, there would be some demand for, okay, what's the national standard for what a mindfulness teacher should be? And you'd see more standardization perhaps around the curriculum that's being delivered. So I think there's a lot of opportunity there, but I think when you move into the medical space, people are always worried about safety and then and harm, the risk of harm. And so when you're talking about patients who are ill, there's a lot of need to sort of protect those patients, and there's a lot of legal layers to working in a healthcare system, such as protecting people's confidentiality, protecting their data, working with all these systems. So I think you'd probably see mindfulness teachers sort of being absorbed into this very complex system that we call healthcare, which may or may not be something they're excited about doing, but being able to reach people who are really ill and who could really benefit from mindfulness practice could also be a beautiful thing and provide a lot of positive impact into people's healing.
Yeah. Yeah. One of the things that in our interviews with policymakers and health insurers is they talked about the value of sort of an accrediting body for, say, MBSR teachers, for example, if it was going to go towards the route of health insurance coverage. And it's one of the reasons why at Brown we've been really trying to connect in, like say with UCSD's Center for Mindfulness that provides MBSR teacher training, as well as the Global Mindfulness Collaborative, that's a network of people right around the world. Mindfulness Teacher Training Association, for example, in the US, so that there's multiple groups that are really committed to high quality MBSR teacher training. That's just a subset of them. There's others as well. One of the things that policymakers actually, I think it was a senator's staffer share with me, before they were going to bring some kind of bill to their boss to bring forward for consideration as a policy, they wanted to know what professional organizations thought about MBSR and its health impacts. And so that's one of the things that has drawn me to some of the work that you're doing with the American Public Health Association, and how you were president last year of the section on like complementary integrative traditional health. And APHA released its first policy statement on integrative health last year. And I wonder if you might share a little bit about what that process was like, and then also how it might weave into the project you and I are currently pitching to the American Public Health Association around a policy statement for MBSR.
Sure. Well, the American Public Health Association, for those who aren't familiar, it's a member organization. I think typically it has around 20,000 members who are public health professionals across the United States. It's 150 years old. It is one of the 5 biggest healthcare related professional associations in the United States, and it's composed of many topical sections. So, like you mentioned, I'm deeply involved in the integrative, complementary, and traditional health practice section. And then across all these various sections, we come together in these kind of across the organization committees. So the policy committee looks at policy proposals from across all these different topics within public health. So we initially proposed a policy related to some complementary and integrative health practices as tools for primary prevention of disease a couple of years ago, and then we went through this rather lengthy process of putting together all the evidence, submitting that to this joint policy committee that was made up of folks from across the organization, getting feedback, responding to feedback. So it was a pretty lengthy process. And this year, they're actually radically shifting what that process looks like. And so we're doing a much shorter policy proposal, and then we'll hear back whether or not there's interest in us putting together something lengthier with more detail, which I think makes some sense to put before the entire organization. But I think this is a pretty powerful venue potentially to share some of the data on mindfulness and mindfulness-based stress reduction across many different health conditions. Like these practices have potential to really contribute more in a more widespread and impactful way to public health initiatives. And I think that's something that folks within the American Public Health Association will certainly be interested in. And I think it'll prompt a good back and forth conversation. I know within public health, people really want to see the evidence, and they want to see the potential for community impact. And I think it'll be a good challenge for us to sort of put that argument together in a really compelling way. And then, potentially reach an even larger group of people on Capitol Hill who are making funding decisions about kind of what we're prioritizing in our public health infrastructure in the United States.
Yeah, yeah, yeah. We have this NIH grant that's doing systematic reviews on MBSR as well as the implementation science side of things. So we're currently synthesizing the evidence on the impacts of MBSR on anxiety and stress and cost effectiveness and stuff. And so that'll be weaving in with some of these hopeful policy statements to be able to just in as evidence-based way as we can and just reporting what we find to allow people to make decisions on what seems best for society around the value of these kinds of programs and to potentially increase access for them too if the evidence supports it. And just maybe shifting gears a little bit towards the access side of things. I know that you are living like in North Carolina, have done some work with Appalachian populations and with folks on lower ends of the socioeconomic spectrum. And I know that sometimes, often enough, we don't see as much research findings in underserved populations or ones that are living in more rural areas, for example. And so I'd be curious to hear more about what you've found around how MBSR or other mindfulness programs resonate with some of the populations that we often don't get to connect with as much in this field.
Well, I think my experience I lived in Texas before I moved to North Carolina, and in both places, I think whatever preconceived notions I had about people from different backgrounds, maybe being skeptical of mindfulness, has largely proven untrue. And I've found that people really connect with mindfulness across different cultural backgrounds and have a lot of interest in it. And, mindfulness doesn't need to cost anything, really. These practices are they don't require anything except your body and your mind. So I think that when people are introduced to these practices, they can be really beneficial, even if they don't have a lot of access to financial resources, and even if they have really complex lives. Finding that peace within yourself can be a really beneficial um, thing to access. Um, yeah, so I think my experience, both with the work I'm doing now with folks in Appalachia who just went through this horrific hurricane, and people who have, in some cases, lost everything in the last few months. I was really amazed and gladdened to see that the clinic we're working with there, that the patients still wanted to go ahead with our group 2 weeks after the hurricane happened in the fall, and that they were really committed to participating, even as people were navigating really difficult situations of homes being damaged or having lost a lot of community members.
Mm.
Um, so I think there's a role for mindfulness in many, many different types of communities. And I think that people, regardless of their life circumstances, appreciate being present with other people and connecting on this level of common humanity. That is something, it's deeply tied to respect, I think. And I think that uh, folks who've been through a lot appreciate that level of being recognized.
Do you find anything um, works particularly well around, like, say, adapting it in terms of, say, qualities of the instructor, or how long the programs are, or whether they're offered by telehealth to avoid commuting? Any particular things that that you feel are best to change, or is it pretty good just as, pretty straight up MBSR, for example?
Well, I guess the program that I've been working on implementing primarily is significantly adapted from
Mm.
the kind of traditional mindfulness-based stress reduction. And it was adapted by a community of folks in the Boston area who were patients in federally qualified health centers. And those folks really recommended that the mindfulness practices be shorter. So we sort of start with a 5-minute awareness of breath meditation and progress over the course of 9 weeks to 20-minute, 25-minute practices. So it's much, much, much shorter than, say, 45 minutes of sitting that we do in mindfulness-based stress reduction. And I think the other thing was that people were interested in additional topics like nutrition and other techniques like self-massage that are not part of the traditional mindfulness-based stress reduction curriculum. So I think all those things need to be considered. And then I think it's always helpful to have somebody who's really familiar with the community that you're working with, and maybe is from that community if possible. I don't know that that's a must, but like I found that in the community I'm working with now, been running this program with a licensed clinical social worker who really knows the stories deeply of her patients, and she knows the traumas that they've been through. She knows what to be sensitive to, and that has just made working on this curriculum much, much easier, because she is thinking a couple steps ahead of what might be difficult for some of the patients. So there are many ways to adapt to a community, but I think that having that we would call context expertise, people who really, really know the community well, is probably key to
Yeah.
thinking about and then of course having the patients or the participants give their own feedback, because it depends on the group, depends who shows up. Not everybody from every community is going to want the same things, or each person's story is unique in that way.
Yeah.
I think it's certainly a need to stay flexible for different
Maybe
communities.
if we think about, like say in the United Kingdom, impressed with the work by the Mindfulness Initiative that has brought mindfulness into like sort of the House of Commons, for example, and that many different political parties have been involved with practicing mindfulness in community settings. And be curious, like, you know, I like to offer as much respect to people's political backgrounds, whatever they are. And I also know in the area that you're working in, you can have folks with different political backgrounds coming into class together. And I'm curious what you notice around how mindfulness is resonating with people from various different political backgrounds in the North Carolina area that you're working in, or Texas.
I mean, I think we don't get into politics in the groups, and but you can sort of pick up on cues sometimes. And I think what I've been amazed by is seeing people really connect with each other who are from communities that otherwise might not speak to one another. And I think that that has to do with that um, connecting on such a deep human level, connecting across folks who are going through the same difficult chronic illness, you know, going through this experience of illness together, and connecting to the experience of uh, navigating suffering, which is what mindfulness is so brings us into awareness of all the challenges we're experiencing in our thoughts and our minds and our sensations. So I've been amazed at seeing people connect across political divides. At the same time, we're not really talking about the politics themselves. But I think that it's always useful to remember that there are people behind the politics, people who are suffering, just like you and me, and that we have much more in common than we have different from one another.
Yeah, thanks. Thanks. Good. Well, why don't we, I'm going to turn to a few questions coming from the audience right now. That's okay. And so one that came up was, aside from 90-minute sessions compared to 2.5 hours, I'm curious what makes the group medical interventions different than MBSR and why it would be covered with a code, but MBSR is not. Can you elaborate on more details of exactly how the sessions are led and by who and what they entail? And I know you've already shared about some of those pieces, but maybe anything that you haven't shared yet around that.
Yeah, can I share an image?
Sure.
So I was talking about kind of one iteration, but this idea of a integrative group medical visit is actually this is a broader definition. So if we look at what people have published about integrative group medical visits, the definition is that care is provided to multiple patients in the same space, whether that's in person or telehealth. It's billed using ICD-10 codes and documented in the medical record, that patients interact with each other during the group session, and that at least one complementary health approach is incorporated into most group sessions. So this is actually kind of a class of different types of programs. So the one I was talking about happened to be delivered in 90 minutes, happened to include nutrition and these shorter meditation practices, but you can deliver mindfulness-based stress reduction kind of in 2.5 hours, exactly as you train folks to deliver it at Brown in this format. The key is that there's a medical provider who is connecting with each patient and addressing some of their health needs in each session. And that's what sort of makes it a primary care visit, is that they're connecting with those patients. So for example, in the Optimum trial, which you mentioned and kind of alluded to in the introduction, which is a trial looking at mindfulness-based stress reduction in a group medical visit format for patients with chronic low back pain, that's being led by Dr. Natalia Marone. The curriculum looked almost exactly like the original mindfulness-based stress reduction program. It was much less adapted than the program that I've been working on in North Carolina. Um, so I think the confusing thing here is that there isn't a specific code for each group, for each curriculum. But you could develop a new code that would just be for mindfulness-based stress reduction. And I think the question there is, what would the benefit of that be? I think if you could have it be that mindfulness-based stress reduction teachers could bill insurance directly without a medical supervisor, that might open up access in some way. Or if the medical provider didn't have to be present and didn't have to write a note and didn't have to check on each patient's health conditions each time, if it wasn't taking up more of the physician's time, that might open up access. But this model still requires a very time-intensive commitment from the primary care providers. Does that make sense? I know this gets a little in the weeds.
Yeah. Yeah. I mean, I think from an administration point of view, they're always having to make decisions on whether the clinician's going to spend their time on, say, a 90-minute session with folks versus doing other things, or a 2.5-hour session with folks versus doing other things. And there's these kind of cost benefit analyses that they're running. And so I think the program that you're doing with Natalie Marone, where you're bringing the core elements of MBSR into a group medical visit that seems to be set up well, I think could be a nice kind of middle way to address this. And I know those results are like, I think maybe under review right now, and you're not allowed to share them too much, but I know that a lot of the research is complete at this point, and so I'm looking forward to seeing the findings from that major study. It's like what's the sample size of that and how many sites?
450,
Yeah,
I believe,
yeah,
and
it's
we
going
had,
to
yeah,
be,
3 sites. So and we were doing the study in a real world population. So we were working with a network of federally qualified health centers in North Carolina and a safety net hospital in Boston, and then University of Pittsburgh in
yeah,
Pennsylvania. So yeah, it's a really interesting sample. And I think it's worth noting that Natalia's previous randomized controlled trial is what led to the changing of clinical guidelines to include mindfulness-based stress reduction as the first line treatment approach for chronic low back pain. So
in the VA
in,
or
no,
in the VA hospital system or elsewhere as well.
no, that's national. I
Yeah,
mean,
great.
her study was in older adults outside the Veterans Administration, um, and now, yeah, there are multiple clinical guidelines that recommend mindfulness-based stress reduction as the first line treatment approach.
Yeah. Okay. Maybe one more question from the audience. So Angie writes, I've observed that peer-based interventions can be remarkably effective healing tools. Having worked extensively in East Africa, where collective healing approaches are culturally embedded and resource efficient, I've noticed significant resistance when attempting to implement similar group-based methods in the United States healthcare context. What strategies have you found successful for encouraging American participants to engage with collective peer healing approaches that may feel unfamiliar but offer substantial benefits?
Interesting question. Uh, so peer healing. I guess it requires a level of self-organization, right? To get peers to bring groups of people together and to come together on a regular basis. And I don't know that I can speak to why culturally that is a challenge for us to self-organize in a way that's not dependent on money or professionalism, but just coming together as a community. I know my book club struggles to get together on a monthly basis. but we try. Yeah, I suppose it's a cultural thing of that we don't have those sort of community rhythms, perhaps. But it's a good question because I think sometimes we look to the medical system to address a lot of society's challenges, and which of course contribute to health and chronic disease, but a lot of these things could be addressed outside the medical system. I guess I'll just point to one really, really exciting example, which is Open Source Wellness, which is a group that they do run and implement group medical visits, but they also are working with YMCAs across the country to do peer groups that incorporate some mindfulness and movement and well-being and peer coaching without the medical piece. And so I think utilizing what we have as infrastructure of community centers is pretty innovative and exciting. But even that is relying on an institution, right? It's relying on YMCAs. And I don't know if I have a good answer to why we're not just self-organizing into groups to support one another.
Yeah, it feels like a bit of a phenomenon in US society and related to the loneliness epidemic that's happening as well, so that we can certainly connect online a lot, but the ability for us to gather in person in groups has lessened over the last decades. And what is that? And at some point, probably the pendulum will swing back the other way, and there may be insights from other cultures, like in the African continent, that show ways forward in that regard. I know we're getting close to time here, and with the speaker series, we're trying to offer a similar question at the beginning as well as a similar question at the end to all the speakers. And so, through your viewpoint, as you look ahead to the future, where do you see the study and practice of mindfulness best serving humanity?
Big question. I think that the study and practice of mindfulness can help us to solve some of our major challenges when it comes to seeing the world differently, right? I think that one of the things that always resonates for me the most in the groups we do is the part about challenging communication and listening to one another. I think we're in a time right now of sharp division, and when we can find ways to approach each other with respectful dialogue, it feels like there's more of a path forward to some of our biggest challenges. And I think there's also benefit in mindfulness practice to thinking about right action, or what some of the strategies we need to approach solving some of our world's biggest challenges when it comes to both health and economics and climate. How can we approach some of these things with strategy and also with compassion? I think that on a kind of individual and systems level, mindfulness can help us to approach these challenges with wisdom.
And then lastly, as you're looking ahead, what are the biggest research questions that you feel could have the largest impact on the field right now in the area of mindfulness? As you're thinking about big innovative questions that could really make a difference at your stage in your career, what would you see those being?
Well, I'm totally biased because I'm in I'm in my own questions, I guess, but I'm thinking a lot about how do we make mindfulness more widely accessible? How do we train and empower people from different communities to share mindfulness practices within their communities in a trauma sensitive way? How do we, should we professionalize the field of mindfulness? How do we interact with government decision makers about making mindfulness a bigger part of health and healing? So I hope to collaborate with many people on those questions, but those are some of the things that I'm most excited about. And there are lots of other questions out there too that I think are also fascinating. But I'm pretty stuck on this issue of access to mindfulness and having more people engage with it, because I've just seen over and over again people from communities who, for whatever reason, are not well represented in the mindfulness space, learning these practices and it changing their lives in a really powerful way. And so I want to see more of that.
Well, I'm really glad you do what you do and that you're here today. And thank you for all the work that you've done so far. But I'm also really excited about all the work to come as well in your career. So it's a real pleasure having you here today. And thank you for joining us. And Fran, anything that you want to share as we come to a close, or?
Yeah, thank you so much to both of you for just allowing us a window into such an interesting topic and conversation. Isabel, thank you for the work that you do. You just bring so much wisdom and care to the questions that you're asking, and we are, as a society, better served for that. So thank you. A couple just quick announcements before we wrap up. So first, we're excited to continue the Evolution of Mindfulness speaker series next month. So for May, we will be inviting Dr. Elizabeth Hoag from Georgetown University, who will be speaking on mindfulness or medication, what the research says about treating anxiety. So she'll share her findings from a landmark study comparing mindfulness meditation to a leading anxiety medication, and discussing what the science tells us about treating anxiety. So I dropped a link for that event in the chat. Feel free to sign up. It'll be on May 29th. And then after the May session, the series will take a summer break, but we'll plan on returning in September with a new lineup of speakers. So stay tuned as we kind of get the schedule figured out. We'll put that on our website. And that is it. So with that, on behalf of the Brown School of Professional Studies and the Mindfulness Center, we just want to thank you again for spending this past hour with us, and we wish everyone well, and we hope to see you again soon. Take care, everyone.
Yeah, thank you, Fran. Thank you, Isabel.
Thank you. Thanks so much for having me.
Bye, everybody. Thanks for attending.